For the next part of our program, we'll be getting an overview of some of the big movements in healthcare transformation in Hawaii. So we are going to have Tom Matsuda from the governor's office talking about all of the activity around the implementation of the Affordable Care Act. Coral Andrews is going to be giving us an update on the Hawaii Health Connector. I'm going to give you a briefing on the state innovation model plan that we are putting together. And Herb Schultz is going to be moderating us. So we're all going to come sit here on the stage and give you the updates.
Okay, I get the easy part, the Q&A with all of you. So let me just briefly introduce our three speakers in the order I think they're going to be speaking. Tom Matsuda is the ACA Implementation Manager in the Office of the Governor. I think many of you know Tom and his work, but he's been coordinating numerous state agencies that have a role in implementing the ACA across Hawaii. He started his position about a year ago after returning home from 25 years, I guess, in the state of Oregon. And in Portland, he represented small businesses and private practice and recently served as executive director of Oregon's largest legal aid society. And he's a graduate of Hastings College of Law. So let's welcome Tom. Thank you. I think many, if not most of you, also know Coral Andrews, the executive director of the Hawaii Health Connector. She has been there since the beginning in December 2011. Prior to that, I think when we first met, you were vice president of the Healthcare Association of Hawaii. She's a retired U.S. Navy captain and holds an MBA and a Bachelor of Science in Nursing, is a registered nurse, and she serves as a regent for the Hawaii Pacific chapter of the American College of Healthcare Executives. So welcome, Coral. And maybe I should just say, here's Beth, but we'll give a little bit of Beth's bio. You all know how and who she is now and how hard she has been working. When we first met during my appointment, she was the executive director of the Association of Federally Qualified Health Centers. She was also executive director of the Kalili Palama Health Center. And as the CEO of the Primary Care Association, I know you spent a lot of time working on health equity, people who are uninsured and underserved, and greatly appreciative. So I think we're going to start out with Tom. Our goal is I'm going to keep them with Andrew, hopefully to no more than 15 minutes each, and we're going to do a Q&A dialogue as well. So, Tom?
Thank you, Herb. Good morning, everyone. You know, we've been focusing on this wonderful presentation by Alan Weil with the history of you know, healthcare in this country and in Hawaii. I'm going to narrow the focus considerably to what's happening locally currently in the state's implementation of the Affordable Care Act. And as all of you know, the current chapter of the ACA that we're in right now is especially focused on the launch of the exchange, the Hawaii Health Connector. And so what I thought I'd do is to give you a little bit of a snapshot into how the various state departments had a role in the implementation of that chapter of the ACA. I see many of you in the audience who have heard my basic stump speech about orienting the community to what the ACA provides, and you'll be relieved to know that I'm not going to give that presentation today. I'm assuming that this is a much more informed and sophisticated audience, and so I'm going to go into this assuming that you understand the basics of the ACA. And instead, I'm going to focus much more on how we did it. Because if you think about it, when the ACA was passed in 2010, and then when Act 205 was passed in the 2011 legislature, we didn't really know how this was going to play out. And now, at least in this chapter with the launch of the exchange, we have answered many of the questions that were unknowns back then, and so I'm going to try to highlight some of those as I go through this presentation. First of all, this is a list of the state departments that have a direct active role and responsibility in the implementation of the ACA. You can see, of course, that the governor's office and the healthcare transformation project, as you heard from the governor himself, is kind of the guiding force and the guiding light in how we look at ACA implementation. And then below that are the departments that are involved. Health, obviously, because of public health. Department of Human Services, because of the Medicaid expansion, which you heard a lot about. DCCA, and especially the insurance division, because obviously insurance reform is a huge part of this. Labor and industrial relations, because they have the statutory authority over the Prepaid Health Care Act. Information management and technology, because obviously IT is a very important part of the entire transformation. And then the Attorney General's office, because we are, bottom line, we are implementing a federal law, and we need to understand what it means. So what I'm going to do next is focus on the individual marketplace as part of the connector. And what I've got here is a diagram that I borrowed from a Department of Human Services presentation that was given by Director McManaman several weeks ago. This is actually a 30,000-foot depiction of the state-based marketplace in Hawaii. The upper portion is the Medicaid system. And as you move from left to right, you are looking at the consumer entering the system to determine whether he or she is eligible for Medicaid, and going all the way through to the right-hand side with enrollment in a Medicaid plan. The lower half of this diagram is the connectors portion of the state-based marketplace in the individual market. And again, it shows from moving from left to right, the individual consumer engaging the system, moving through eligibility, the tax credit determination, and all the way through enrollment in a system. So this is the entire individual marketplace system that has been constructed and is currently live in Hawaii. This portion right here is, as I said, is the Medicaid piece, which DHS was responsible for constructing. They also had a very important role in building the first stages of what we call the state hub. And this is actually shown in two parts on this diagram, but it is actually one system, but it's shown as two pieces because both Medicaid and the connector engage in the state hub to access the federal verification system. Here is maybe the most critical part of the integration of the two pieces. Most of you know that in order to get the individual tax subsidy, it is a prerequisite that the applicant must be denied Medicaid first. So the upper circle is the Medicaid denial, and that is transmitted electronically over to the connector in order to make the tax credit determination for the individual. So that's why these two systems are linked because of the law. And then here, what I've circled is the piece of the connector individual marketplace where DCCA and the insurance division had a very important role because they had to first qualify the insurance plans that were going to be sold on the connector and to make sure that those plans met both state law requirements and also the Affordable Care Act requirements for insurance plans. So the DCCA staff were very heavily engaged throughout this process with the connector staff in making sure that that part of the system would work. Let's now look at the other part of the marketplace, which is the Small Business Health Options Program, otherwise known as SHOP. And this part for the state was really very important for us because we had to figure out how to blend the state law, the Prepaid Health Care Act, and the ACA requirements. I think all of you know, and some of you have seen this slide before in my presentations, but on the right-hand side is the Affordable Care Act levels, what we know as the metal levels for the quality of the insurance plans that are to be provided under the ACA. That's platinum, gold, silver, and bronze. One thing that we did not know when Act 205 was passed was exactly how that would mesh with the existing state law requirements for insurance plans, which are known as 7A and 7B, and the quality of those plans are primarily driven by the market. That is maybe the single most ingenious part of the Prepaid Health Care Act. So the single most commonly sold plan, or the prevalent plan in the marketplace, is what is known as the 7A plan. And then 7B plans are a slightly less expensive, lower quality alternative that's available to employers in this state. Well, what we know today is that our estimate is that the actuarial value of 7A plans is at or exceeding platinum by the ACA standard, and the 7B plans are at or exceeding gold. So this is yet another reason that it's very important for us to try to preserve prepaid within this system. Now, within the Prepaid Act, there were certain things that we had to comply with for the ACA, and this kind of boils it down to the summary. The DCCA in qualifying plans within SHOP had to make sure that they were qualified health plans as defined in the ACA. All of the plans also had to meet the 10 essential health benefits as a minimum standard. And out of the 10 standards in the ACA for the EHBs, there were only 4 that were typically not present in our plans. So that was not as big a reach for us as it was for other states. And then finally, of course, the other thing that was available to prepaid that's new is the small employer tax credits that are only available to small employers by going to the connector. So this is how we solved the problem of the integration of prepaid and the ACA. Basically, if you are a small employer going into the system at SHOP, at the connector, you are filtered based on the answers to your questionnaire into these 3 categories. If you are an employer, a small employer who is currently subject to prepaid, then you will be directed into the prepaid portion of the SHOP portal. And your experience there should be basically the same as what you have now in your ability to choose either a 7A or a 7B plan. If you are one of the few employers in the state who is not subject to prepaid, then you go into the non-prepaid portion of the connector, and there you have strictly ACA choices for your insurance plans. And then if you are ineligible as an employer, you are directed into the individual marketplace. To get to this point and to make it work took a lot of work and coordination and many hours of effort between the connector staff, and mostly the staff of the Department of Labor and also the insurance division. Excuse me, I went through this already there. And so this is the last slide that I've got, and it shows you how the choices for the various employers are laid out currently in the system. If you are an employer who is subject to prepaid, you choose first between 7A and 7B. Then you choose a reference plan, which sets the benchmark for how much you as an employer have to pay. There could be a range of plans that are available. Some of them could be more expensive. And if your employee chooses a plan that is above the cost of the reference plan, the employee has to pay the difference. So that is a way for the employer to determine how much they're going to have to pay totally in premiums. And excuse me. And then the final choice is, and this is an option, a policy choice that was decided by the connector board, the employer at that point could choose, if they want, to limit plans to just one insurance company. And then after that, the employee is informed. They go onto the system and they can choose a plan from among the ones that are chosen by the employer. And then they can make a choice about whether to include dependents. Okay, so that's under prepaid. Under non-prepaid, it's a very similar choice, except instead of 7A or 7B, you are choosing from among the ACA qualified plans that are made available. You also can choose the reference plan, and you can also have the option of choosing one insurance company. And then, again, the employee is informed, and they make their choices. So this is, again, a very high-level explanation of how we solved the integration of ACA and prepaid. That's really the end of my presentation and the snapshot of how we engaged with the connector to get the system up and running. Thank you very much.
Thank you, Tom. Now we're going to go to Coral. And I know we have cards on the table, so maybe you're already scribbling, so just we encourage you to do as many questions as you like, because everybody's going to be here throughout the day, and if we don't get through them on the stage, our hope is that we'll get through them by seeing everybody.
Well, thank you, Herb, and I do want to acknowledge and thank the governor. I know that he stepped out for just a moment, but I do want to take the time to acknowledge his courage and leadership in being the first state to declare its intent to establish a state-based marketplace, all of that of which was going on at a time when our nation was debating the Supreme Court ruling. And I think, again, it shows that Hawaii has courage in things that it feels passionate about and those things that it feels very committed about for its community. So I want to acknowledge and thank him for that. The Hawaii Health Connector is a state-based marketplace. Among all of the national dialogue that you're hearing, there are several different kinds of marketplaces. Hawaii, it was important that we established a state-based marketplace because of the need to build upon the Prepaid Health Care Act, which has been around since 1974. The Affordable Care Act affords us additional flexibility atop of the benefit and values that we've already seen and realized here in Hawaii with a relatively low uninsured rate of about 8%. I'm appreciative of this opportunity to be here today and to look out across the audience and share this time with so many of my healthcare colleagues from throughout the state, for the many islands being represented. I know all of you are passionate, as am I, that we achieve an appropriate state of health and well-being for our communities. This is a journey. I've heard someone say it's a marathon, it's not a sprint. And so, as the speakers before me have said today, it's important that we really take the tools that the Affordable Care Act gives to us and put them into motion for the benefit of our community. But for Hawaii, it is a state-based marketplace, and there are about 16 states that establish state-based marketplaces. So as you're filtering all of the information that's coming at you from the national level, recognize that there's a federal marketplace for states that perhaps wanted to take a wait-and-see approach or politically needed to sort of work out the differences of opinion. But for us, we have the good fortune of not only being able to preserve the Prepaid Health Care Act, but also to weave culture into the brand and into the way that we interact with our community in implementing this law. What is the purpose of this insurance marketplace? There's certain themes I'm already beginning to hear that I anticipate will resonate throughout the rest of the day today. One of those has to do with helping consumers to be able to have information shared with them in a way that's more easily understood. The Affordable Care Act, as I've shared in other presentations I've given, intends to put the consumer at the front of the bus. This is about design thinking and taking the consumer and shaping a model from the consumer's perspective outward. As you heard in Dr. Weil's presentation, or Alan's presentation, we look back through history at all the different models that have been developed either from the motivation and purpose to be able to drive down cost or to design new models of care or to access or to address access. What's critical is that we anticipate how we design models from the perspective of the consumer's ability to use them. We can create different models of care, but it needs to be done in a way where the consumer understands how to access them. And that's about health literacy. And we have an opportunity to leverage these tools to promote health literacy. So our objective in developing a marketplace of transparency is to put information out there so that it makes health insurance easier to understand, easier to purchase. I don't know how many of you have been involved in a golf course conversation. I unfortunately don't golf, but look forward to learning how. But I heard a friend of mine describing a golf course conversation, and these are professionals, people that have held very high, distinguished jobs, many of whom, if I said their names, you would know. And they are struggling to sort of understand, well, how do I make decisions about Medicare? How do I make decisions about health insurance? So understanding the purchase of health insurance is not just at a specific level of education, it's for all of us. It's a very complex thing as I look down at my colleagues that are in the business of selling health insurance. I give you all a lot of credit. It's a difficult thing to articulate. We want to make sure that we ensure equal access to health insurance. One of the key themes that I've already heard this morning, and I believe it was the governor, is that we have an obligation to care for one another. Yes, in Hawaii, we have an 8% uninsured rate. But as a clinician, I often struggle with the question of why should one be any less than the others that we care for? Our society will prosper if we're able to provide health equity, access to health services for everyone, and not just a 96816 product, something that goes across our whole state. The marketplace also seeks to provide a means for us to choose quality health plans. As Tom said, there are essential health benefits that standardizes the product that's sold, so it takes out the confusion the consumer struggles with about what is in the plan. At the same time, the Affordable Care Act establishes quality ratings, which will be coming online to further give the consumer insights into the products that they're making choices about purchasing. And also to serve as a bridge between the private health plans and the public health plans. We've heard Cindy Mann talk about the progression of the Medicaid program. We, within the connector, all fall under an umbrella, as we share similarly with Medicaid, under the Centers for Medicare and Medicaid. CSIO is the agency that administers our grants and oversees us and regulates us. CMCS on the Medicaid side. What you're seeing government go through is a bridging of cultures. Even between CSIO and CMCS, there are different business cultures. The entitlement programs have a long and distinguished history. We're embarking in a new role for government where they're taking plans out to a private market and putting them out for sale. It's consumerism. Our organization is built off of customer relationship management. It's about making sure that we provide a good value for the customer so they're going to want to come back. And attempting to shore up gaps, again, the 8% uninsured rate that does put cost on our system, and as many healthcare providers in this community know, continue to result in cost showing up elsewhere through the healthcare delivery system. We're more than just a website. I can't in about 5 minutes explain to you the difference between the what a website is and the intelligent app and a web portal, but I think Tom's slides did a wonderful job of showing the multiple complexities of the system and the connections to the various federal agencies and other hubs. We work very closely in coordination with both state and federal government. So this is an opportunity and an example of how public and private partnerships can collaborate. We're implementing new technologies and doing so as, again, federal and state systems come together. And working under aggressive timelines. I'm here to demystify, as Tom has encouraged me to do this morning. No, we haven't had 2 years to build this. Our procurement was completed in December of last year, and we worked under an aggressive timeline to get to October 1st like many other states. I look out at Steve Robertson, and I'm sure he can feel my pain here in implementing electronic health records inside Hawaii Pacific Health. I've heard these implementations typically take 3 to 5 years. So to put it bluntly, we've been busting our tails for the last 11 months. What are the milestones ahead for you all to keep your eyes on? December 15th is a critical date. We're in open enrollment, which runs from October 1st through March 31st. December 15th is the date by which, if plans are purchased, the plan benefit goes into effect January 1st, 2014. March 31st, again, is the final day of open enrollment. And I've borrowed a phrase from a colleague at CSIO when I share with you, we are literally building this plane as we're learning to fly it. And the story has taken on even more dimension to that. We're building the plane as we learn to fly it, as someone's doing a paint job and they're changing out the windshield and et cetera, et cetera. So it requires, as leaders, a different skill set. You have to be planning forwards and backwards. You have to be adaptive. You have to strive always to focus on mission. And don't lose sight of the things that are going to get, as the governor told me once, stuck in the saddle. It's about our community. It's about our people. And as long as we stay focused on mission and that commitment to delivering a greater prosperity for our community here in Hawaii, then I feel very positive of our ability to be successful. Here's what we can do. This is the other thing I'm going to demystify. We're very fortunate in Hawaii. Yes, we got off to a little bit of a slow start compared to others, but our site has been up since October 15th. It has not crashed. It has not had rolling ups and downs. And we have more functionality than many other states. We don't say that in a way to shame someone else, but I'm here to stand proudly to tell you that we do. And some states actually don't have an exchange up and running right now, and you don't hear about that either. So here's what we can do. We can create an account. Consumers can go on and enroll. And the face of the uninsured, as was shared in the midweek article when I was interviewed, does not have a face. It's our friends, it's our families, it's people we know. And you can do this in a secure environment. We were overseen by the federal government. There's security standards we had to comply to. It's a secure environment. Please help us get those that you know enrolled. We can determine eligibility. They can go on and they can apply for financial assistance. We work very closely. And I want to acknowledge the leadership and work of the Department of Human Services in getting their COLEA system up and running. It was a very big lift for them as well. We have issuers, both health plans and dental issuers, who've collaborated in this process, and Hawaii has 95 plans to choose from. People can drill down and filter and look for options and choices, more choices than they've had before. They can shop and compare, and you can shop and compare in all the different metal levels that Tom showed. And in Hawaii, in the prepaid side, they can continue to look for the 7A and 7B plans. And that was an extra requirement that Hawaii had to be able to work closely to hold on to the Prepaid Health Care Act, preserve that. And you can choose a plan. So what is our larger role in transformation? We're here to operationalize a concept. Just implementing a health insurance marketplace doesn't fully achieve transformation as a whole. But what it does demonstrate is our ability as a state to collaborate between public and private partnership. For policymakers in the room to test the waters in examining what are these hybrid models and how do we bring them together. Business cultures will need to evolve, as well as legal contemplations about how these business environments, public and private, come together to achieve these. Having a concept is one thing, but you've got to drill down further to be able to operationalize it. And catalyst of change, you've heard Herb talk about that. As leaders and in the work that I've done with the American College of Healthcare Executives, and we're reading about this through national journals, you cannot take up space on a bench. You have to be willing to take risks. It's uncomfortable being in a position where you're constantly taking hits at the press or getting caught up in a national political dialogue and debate over whether or not people across the United States should have equal access to health insurance coverage. As a clinician, I can tell you that absolutely I affirm that we should provide access, equal access to all in our community to health insurance coverage. And lastly, I would say we have real stories. We have real stories we'll continue to work to share with you. Throughout our state, we have program specialists on every island. This is of Hawaii for Hawaii. We've worked to design this brand so that we build from our communities. We know that information is shared person to person, and it's shared by the people that you trust to the people that will receive that information and who trust you. It's critical that we continue to work together as partners. This is tough work. Leading change, sometimes, as I've heard from the Omidyar Fellowship Program, of which our legal counsel was distinguished selectee for this year, what we need in Hawaii is risk takers. We need for you to be able to stand out and to lead. And so I ask for your continued support. I ask for a call to action to help us get people enrolled in these programs. And I thank you all very much for your continued support of the Hawaii Health Connector.
And our last speaker, before we open up for Q&A, Beth?
Again, happy to be with you and really happy to share with you our roadmap for healthcare transformation. I'm going to gallop through this because I know that we have spent more than 8 months working with more than 100 people, countless meetings, lots of work has gone on into this, lots of detail. And I encourage you to talk to staff who are going to be at a table in the vestibule for additional details, but I'm really going to hit the highlights in my presentation this morning. So, as I get started, though, I do want to spend some time talking about why we are engaged in transforming our healthcare system. And so let me start with this hypothetical profile for Frank. Frank is 55, overweight, diabetic with a cluster of other health problems. He has high blood pressure, high cholesterol, kidney disease, and peripheral nerve damage. In addition to that, he is at risk for a whole host of other health problems. He sees 4 specialists, and he takes 7 medications. So you can imagine the consequences of our fragmented healthcare system for Frank and his family. In a case like this, who is coordinating all of the appointments with all of these specialists? Who's sharing the information amongst all of the physicians about the various prescription medications, about all the different diagnostic tests? Who's making sure that Frank knows how to monitor his blood sugar and taking control of his blood pressure? Who's making sure that he understands the warning symptoms for any of these other conditions that he may be subject to? So unfortunately, we see an increase in our society in the number of people who have chronic and complicated healthcare problems. And our healthcare system simply is not working for the needs that we recognize. And so, as we heard earlier today, the system is inefficient and costly. Just to go quickly through this, 30% of the health care that is delivered in our system is completely wasted. That is an estimate from the Institute of Medicine. We also know that this is really a crucial problem for government. Not only is it an important public good, but state government here in Hawaii is providing coverage for about 40% of the residents. If we add in all of the federal programs, more than 60% of our population has coverage from public sources. So we know that our healthcare system is inequitable. So currently we have about 100,000 people who are uninsured, and that's been our carrying capacity for a number of years. We certainly hope that that number is going to be going down soon. The majority of the people who are uninsured in our state are below poverty, or below 200% of poverty, and so are very likely to get coverage with our Medicaid expansion. We also know that it's not just people who are uninsured who experience disparities in inequity. That also relates to various populations and various geographic areas in Hawaii. Our system is unsustainable. I offer you this. Even in Hawaii, our grocery costs are not as high as are illustrated here by the American Institute for Preventive Health. In 2007, comparing what grocery prices would be if they had risen at the same rate as healthcare. So, today we are focusing on healthcare transformation, and I do want to put that in context because transformation for me is really the big picture. Transformation is what we get when we align all of our payers and our providers to deliver healthcare with the patient's best interests in mind, with outcomes, and with efficiencies. And so if we look at this illustration, healthcare transformation really is the big picture. The Affordable Care Act is indisputably an important catalyst for helping us make it through this system. And then the insurance exchange is an important tool to make that happen. But all of this is in the context of healthcare transformation. And so that's what we've been working on. We were fortunate to get a federal grant that started last April. It officially winds up at the end of this month. It was to create a comprehensive plan that would affect 80% of our population for the good. We also wanted to make sure that we were paying particular attention to the health disparities here in Hawaii. But these are the various elements that we are trying to address in our healthcare transformation plan. So first of all, patient-centered care. Of course that means patient-centered medical homes, but we're also talking about a much greater level of care coordination, of looking at chronic disease management, dealing with behavioral health, which is one of the most persistent, unaddressed problems in our healthcare world. We want to make sure that we have better linkage for oral health, particularly for our kids. Superutilizers is part of this picture too, because that's where there is a disproportionate amount of cost going into the system. And we see telehealth and other kinds of things going into the system as well. Payment, clearly, is very important because we get what we pay for, and we have not really liked what we're getting too much. So we are working with our payers to try to make sure that we have aligned quality, outcomes, definitions for care. We really need to get everybody lined up to make sure that our healthcare system is working effectively and that we are reducing the administrative complications that don't really add much to the value of our healthcare system. Workforce, well, we already know that we have workforce shortages all over the place, but what we realize as we're looking at our transformation plan is that we need to really define our workforce differently. The workforce of the future, to be patient-centered, is going to require that we have a teamwork model in place, and we don't train people right now as part of a team. We also are going to need people in that team whose responsibilities and whose roles in the healthcare workplace don't even exist right now. So we really need to put together a structure to identify workforce in a different way to ensure that we do have the people who are going to be taking care of us and reaching our goals for healthcare transformation. Health information technology. So in a large sense, we can't even talk about transformation without effective information. And that's what the technology systems now can bring us. We need everybody using electronic health records, being able to and engaging in exchange of information all across the healthcare team and all across the healthcare system. We also need to provide timely feedback to our providers to ensure that they're able to continuously improve the kind of care that they're delivering. And we also need to build out that all-payer claims database so that we can develop baselines and track trends over time so that we know whether or not the things we're doing are improving the healthcare system. Policy and structure. Well, I work in the governor's office, so this is maybe the most important and exciting part of healthcare transformation for me. Because as we're talking about changing all of the healthcare delivery and payment system, I believe that state government needs to change the way it works with the private sector, which is largely where healthcare takes place. And as we are demanding that all of our healthcare system be working in alignment and getting out of silos, so too state government needs to get out of our silos and work in alignment. And so we are looking to establish a structure that's more effective for healthcare transformation and bringing all of the very useful and important parts of government that are now kind of scattered around and not all focusing on healthcare transformation in the same way at the same time. We need to use those levers of policy, funding, and programs. So, last but probably most important is health. We know that our health status is not necessarily affected by our healthcare system. Only a fraction of our health status is due to the kind of care that we receive. We also know that if we don't improve health status, we will never have an affordable healthcare system. And so this is probably the hardest part of healthcare transformation, because this is not in our power to change just by changing the healthcare system, which is in itself a fairly daunting task. But in fact, changing health requires everybody and every policy to be working in sync. So that certainly requires public health, but it also requires the Department of Education, it requires transportation, the environment, public safety. Everybody has got to be on board in this. Now, in our transformation plan, we are talking about trying to find resources to give to serve to the communities where there's a disproportionate number of people who are disadvantaged and help them to come up with creative ways to incentivize better health in those communities. So, the result of our plan, we expect to be reaching out for the triple aim, as we've already talked about, better care, better health, lower costs, but for us, it's the +1, and that is aiming for greater equity and addressing health disparities. Status quo is not an option. Healthcare must change. The government needs to lead and facilitate system-wide improvement. And the healthcare sector needs to be aligned, working in collaboration and working in cooperation. So the road ahead for us, we are completing our planning grant as noted. We are also working on a process to prepare for the next cycle, which is the implementation grant. And that could be as much as $60 million over 3 years to help us do the things that we put into our plan. Meanwhile, the work goes on. There is lots that we can and must do to change the healthcare system while we're trying to gather up the right resources and create the right structure. But the structure is also on our agenda, and so we will be going to the legislature next year, and we will be asking for legislation to create positions and resources to try to start moving things around so that we do have the structure for healthcare transformation. So that's really pretty much it. I, again, encourage you to talk to staff and look at the materials that we have posted on our website that's listed here. I'd also like to recognize my staff, many of whom, unfortunately, are going to be leaving my office at the end of the month when our funding ends, but they have been fabulous. And I'd also like to use the opportunity to recognize the Hawaii Primary Care Association, who has been an invaluable resource to us as well. So that's it. Thank you.
Terrific. So as I'm waiting for the cards to come up, I appreciate, Beth, your sort of last focus on the social determinants of health, because I think that's the way from, I think, the federal government perspective in looking at the Affordable Care Act, it's not just about health care coverage. You look at the social determinants of health, the national prevention strategy, and all of those levels of education, transportation, housing, environment that must all be a part of the equation to transform healthcare. So let me take it sort of back to an access question, because each of you have sort of mentioned some in detail about the Hawaii Health Connector and those things. And Coral, I think there's lots of analogies going on today where people are using, we're flying the plane as we're building it, right, or the car or train or whatever it happens to be. So I'd like to ask the panelists, and sort of looking at it now from the view of, we're in this 6-month open enrollment, we're about 7 weeks into it, which I think provides a lot of context. What do you see sort of moving forward, each of you, as the challenges in facing, because I think we all agree what the goal is, and the goal is to ensure that every individual that does not have coverage, every small business that has not been subject to prepaid, now has multiple options within this Hawaii Health Connector. So what do you think the challenges are moving ahead over the next couple of weeks, getting to December 15th, and then March 31 in getting this sort of off the ground?
If I can go first, Herb. By far, from the state's perspective, the biggest challenge is making sure that the community out there is informed about these opportunities that they have, and especially focusing on the uninsured population. You know, we've done maybe 30-odd public presentations so far to just try to inform the community about the ACA, but there's just a lot of either misinformation or folks just don't know about what these opportunities are. And I'd really like to ask all of you to help us get the word out. We really are aiming to try to get coverage for that 8% of the population that is currently uninsured in this state. A lot of those folks are eligible for Medicaid, and they may not know it. And so they need to be able to get to a Medicaid office or access the system online to apply and see if they're eligible. And if they're not, then they probably have an opportunity for the tax subsidies that are available through the connector for an individual plan. If we could also inform small businesses about the opportunities that they have, especially for the small business tax credit, that could help make their costs more affordable. So really, again, if I could just ask all of you who know about this to help us get the information out, and if you have any ideas for how we can reach those uninsured populations, please let us know, because we'd like to take advantage of your networks in the community to reach out to those folks, get them the information, and help them get coverage.
So, you know, emphasizing, I think, what the governor said on the stage, but also to many of us privately, it's retail.
Yes.
Beth?
I think I'll pass on that question because Tom said it as much better than I could.
Okay. One from the governor's office. Coral?
Well, Tom and I have had good fortune of spending a lot of time together being out on the road, and I would build upon what he said as well. I think that, you know, it's going to take a community working to share information with people that you know who are uninsured. So we do a lot of presentations, and maybe some of the information comes to you or comes to someone in a small business, but it may not apply to you. What we're finding is that the face of the uninsured isn't necessarily someone that is just on the side of the road or impoverished. You know, economically, we have a lot of folks that are uninsured, and some of those stories are beginning to come out. I know John Cruz, the musician, spoke out about it. We have friends who lost jobs with Aloha Airlines that are still unemployed. So I would just say that there are many ways that people can get access to the information. We have our Hi'iola program, which have marketplace sister organizations statewide. You recognize those names. They're available on our website, hawaiihealthconnector.com. I would encourage people to go there. They can fill out a paper application. They can fill out an application online. We have a call center. So the program was set up not to assume that everyone needed to be able to own a computer or know how to use one. We have many different ways, and there's language support. I'm also very proud to say that we've worked to ensure that the host language is acknowledged in the development of this organization. And the interactive voice recording does have the Native Hawaiian language. So we know there are health disparities across different populations in our state, and I would just ask that you all get out and let people know there are many ways they can get that information. They don't have to own a computer.
Okay, I guess one more while we're waiting for the cards. You know, I think all of us that are doing work in our communities around transformation, especially now around the immediate implementation of probably the biggest piece, coverage expansion in the ACA, you know, finds that there is a lot of misinformation out there. You know, some of it is, I think, just because people are coming up to speed in communities. Some of it is also obviously in a context that's, you know, 5,500 miles away and happening in state capitals across the country. So it's one of the things that my office is able to do, and in giving my information earlier, if anyone wants to be added to, I forgot to give this PSA to our listserv, please. We send it once or twice a week. I'm not going to send you a 300-page regulation and say, what do you think about it? I would like to know if there's issues. But to keep up on a lot of what we try and do is help you at the state and local level counter the misinformation, counter those things. I'm interested from the panelists' perspective, what are the biggest sort of pieces of misinformation that you're hearing from those 30 meetings or the work that you're doing? Because I think it's important to share, you know, that experience in terms of people feeling in communities like they're not alone. Because, you know, last week I heard the microchip one again, that every member of, you know, the community that's signing up for coverage will be implanted with a microchip. Now, that's an outlandish one. But I've also been the recipient of ones coming to Medicare beneficiaries who are covered and don't need to worry about the connector that actually came from my mother-in-law. So, you know, when it's spreading through the country and your mother-in-law sends it to you, it's a problem. So, Tom?
One that I've come across in our public presentations, this is fairly simple, but a lot of older folks are worried that they have to do something. Right. And so when I get to the discussion about the individual mandate, I make sure to let people know that if they currently have coverage of any kind, whether it's Medicare, if you're elderly, or Medicaid, if you're lower income, or if you have insurance through your employer, you've satisfied the individual mandate. And it's interesting, you can feel the room relax. And then they start listening to what the options are and how they might be able to take advantage of the system, especially the tax incentives or subsidies.
Coral?
Well, my list was growing, but I'll start with a few. One at our last board meeting was to try to overcome the mystery that it takes 4 hours to complete the application. It doesn't take 4 hours to complete the application. It is an intelligent application. There are required questions the federal government asks. Are you a smoker? What's your age? We were able to get through the application in 20 minutes. I know that not everybody can get through it in 20 minutes, but there is assistance through the call center that you can leverage, or in-person assistance to get through the application. The other is that consumers don't have a voice. The consumers do have a voice in this process. We try to do that through the public forums of our meetings. We have a community outreach committee. We're looking to create a process by which consumers do have a voice. And lastly, Hawaii's doing worse than anybody in the nation. I can tell you that I'm on calls weekly with state-based colleagues across 16 other states. Everybody's dealing with very similar issues. These are robust technology systems that we've rolled out. They will continue to improve over time. But I would just say that Hawaii should stand very proudly that there are, as I showed you on the slides, people can enroll, they can pick plans, they can purchase insurance. And so I would say those are the mysteries that I would like to demystify.
Well, and as I've traveled around, my region and listened to 9 other regional directors, what I hear sort of the most, and I think what's helpful in having this dialogue and spending this day and building, even more energy, is that there still are, significant, I think, millions of people that think the only way to sign up for a marketplace, state-based, federally facilitated partnership is online. And to the governor's point this morning, you can sign up the old-fashioned way through paper applications. You can work with local counselors that are funded through the federal dollars that come for the first year. And that's an important thing. A lot of people don't know that there's an option or several options to enroll. So we have 4 great questions. Let's see if we can get through them. Coral or Tom, when will the connector begin to process SHOP applications, and when will they be able to get a tax credit if there's a delay in the processing of applications?
So we do have SHOP employers who have been able to get their applications processed. There is one improvement coming in the system towards the end of November, which is the 1.5% times the employee's salary. But they can go ahead and go on to SHOP. Employers can, and receive some assistance through the call center if needed. So I would say employers can come on now and put their employee rosters on, and we can leverage the call center to assist you if needed in being able to get your employees enrolled. But there is a capability to do that now, and we know because we've gotten applications through.
I'm going to pull rank because I'm told we're out of time, but I think this is an important question, so sorry, but I'm going to do this. How do you encourage PCPs to spend more time for patients instead of making them see 8 to 10 per hour? This is a quality of care. This is a quantity care, not quality care. We want quality care. Beth?
And that really is one of the issues that we're grappling with. I think that the people who are all engaged in transformation and converting to a patient-centered medical home, they understand where we're going. But we're kind of caught right now being part of the old system while we're leaping off into a new one. And so it is going to require still some amount of work with all of our insurers as well as our providers to make that transition so that the physician or the primary care provider can spend time more appropriately and have other people on the team who are going to be contributing where they should.
And there are significant reforms on the delivery system side that many providers and insurers here and across the country are participating in, which actually are having major effects on and impacts on looking at quality, not quantity, through integrated, coordinated care. And as we end, there was a question about workforce in Medicare and Medicaid and payment rates. I'll just say that there is a workforce panel, but the important thing is that the ACA gives $11 billion to primary care providers over 2013 and 14. There are already bonuses on the Medicare side, and those are bringing in additional or keeping additional providers into the system. There's also some questions about telehealth and telemedicine, and Beth, I think in your session, you're going to be talking a lot about transformation and where to go from the sort of current use of telehealth to telemedicine. So let's give our panelists a big round of applause. And now the moment you've been waiting for. I'm going to turn it over to Beth, and she's going to say, here's the individual rooms to go to so that we can start breaking down and having people in an even stronger dialogue. So Beth, can you give directions to folks?
I will be glad to point people back to this document with the breakout sessions and the diagram of the rooms. And we appreciate your patience. We ran over just a little bit, but we've almost caught up. So thank you, Herb, Tom, and Coral for this morning, and we'll see you again at noon.